I'm going to present is a combination of MRI with CT and whatever modality is appropriate. Rather than making this a stiff academic exercise, I thought I was going to present 30 cases which are to some extent appropriate for their category in neuroradiology. It should take me about 30 minutes or maybe 40 minutes, and then question and answer. In the meantime, if you have a question during the lecture, just let me know. Of the congenital abnormalities, those with a morphological abnormality, I chose Chiari 1 and Corpus callosum dysgenesis, and on a more cellular level, Adrenoleukodystrophy. So this is a Chiari 1, and I'm showing you the image where it is least obvious. But should you be presented with a standard axial sequence, you look at the first slice here, and this is in the cervical spine because you see the odontoid process, and yet you see tissue here behind the cervical cord. So these are low-lying tonsils. It becomes more obvious on the coronals. See them like that here. And most obvious on the sagittal, where they protrude down here to the lower edge of the atlas. Robbie, these are pecs.
Pardon?
These are pecs.
I'm sorry, no,
Didn't we discuss the term pec-like? Was it with your?
Okay.
At any rate, this protrusion of the tonsils has been likened to a pec-like caudal placement. I'll show this to you later. So Chiari 1. There are 4 Chiaris, 1, 2, 3, and 4. Quite a few texts actually mention 1, 2, and 3 only. There is no more a 4. And just remember that it's not like a Chiari 1 becomes a Chiari 2 becomes a Chiari 3, okay? These are different malformations. They just happen to have some similarity.
Dr. Hardjasudarma, any protrusion below is Chiari 1 into the foramen magnum?
What distance?
Is 5 millimeters or is it?
In the newborn, up to 5 millimeters below the foramen magnum is normal. In the adult, 3.5. Now, whether you're going to start calling it a Chiari when it's 4 or 3.5 depends on how fanatical you are about Chiari. You know, I've worked with people that call almost everything a Chiari, and others that don't.
And then the other thing is on axials, if it's at the level of the dens, it is.
That's low.
Yeah, it is low. So that's also goes for herniation. When you're looking for herniation, if you see anything at the level of the dens on axial CT,
Same thing.
then you call it's herniation in a trauma patient.
Okay, now, corpus callosum dysgenesis. Normally when you are at the mid to higher level in the head, you shouldn't see what are almost parallel lateral ventricles. You should see something like this. If they're parallel like that, that smells of dysgenesis, of which this is an example here. You see the anterior portion of the corpus callosum is formed, a little bit of the body, and then nothing. And the way the corpus callosum is formed, it is from the anterior genu, lost my arrow, anterior genu to the splenium, and then the rostrum is last. Adrenoleukodystrophy is one of the many confusing abnormalities that are broadly categorized under toxic metabolic diseases, demyelination or dysmyelination. And they are extremely complex, for me at least. But I chose this because it is one of the few of those entities that, for some reason, affects primarily the posterior portion of the brain, initially. Okay. In the advanced stages, these diseases look like each other. It's like in, with apologies to Dr. P, who is not here, but in chest radiology, it's like end-stage lung. I mean, anything toward the end is end-stage lung. But if you are shown this, and this is a child, and there is what looks like a dysmyelination in the posterior portion of the brain, think very hard about adrenoleukodystrophy. As you can see, he didn't make it, and these are the brain specimens. So, just a few words about that entity. It's a disorder of peroxisomal fatty acid beta oxidation, and that causes very long chain fatty acids to accumulate. The posterior portion of the brain affected early, and as I said earlier, in the late stage, similar appearances as other destructive brain disorders. Vascular abnormalities, we'll discuss briefly aneurysm, AV malformation, developmental venous anomaly, and cavernous hemangioma. This is an aneurysm in a rather unusual location, i.e., where the vertebral arteries come together. And as you know, in the posterior fossa, actually the most common location is basilar tip at the other end. This just happens to arise here, and this is from a sagittal CT angiogram. This is the coronal. This is just a MAC view of this. And this is the 3D reconstruction. Aneurysms in the posterior fossa account for about 20%. The majority, 80%, are from the anterior circulation, of which the most common locations are ACOM, PCOM, and then M1 segment. They initially start out as true aneurysms. In other words, they have all three layers, but eventually they wear out the inner layer, so they only have two layers. And this is the angiogram. This is the lateral of the vertebral angiogram, and this is the aneurysm here at the bottom of it. And here's an 8P view. Aneurysms are called giant when they're about 2.5 centimeters or larger. Large if they're a centimeter or larger, and then small if it's less than a centimeter. They normally look nice and round. If they look a little bit pointy like that, this is usually an indication that it has ruptured. AV malformations. Well, the sine qua non is you have to have something like a bird's nest. And then you see this here, which is early venous drainage. So bag of worms and early draining vein is an AVM. Developmental venous anomalies, or nowadays venous previously called venous angiomas, are anomalous veins separated by a neural parenchyma. This is important. So there is normal brain tissue in between. In between what? Well, there is a large vein and smaller draining pedicles. They're usually uncomplicated, but they can give rise to seizures, headaches, intracranial hemorrhage, especially if they are associated with a cavernoma, in which case invariably it's the cavernoma that's the culprit. Medusa was one of the three Gorgon sisters. Correct me if I'm wrong. And you turned to stone if you looked at her, is that correct? Thanks, Robbie. And this is a nice example of a developmental venous anomaly. So you have one major vein and then smaller radicals leading into it. Here are the axial projections. This patient, in fact, had several of these DVAs. So this is according to the work by Russell and Rubenstein in the 70s. There are 4 cerebral vascular malformations: telangiectasis, venous angiomas, AV malformations, and cavernous angiomas. Now the cavernous angioma is a collection of irregular sinusoidal spaces of varying sizes. And the blood that's in those little compartments is static almost. So it just sits there and then it ruptures. And then it becomes organized around the initial cavernoma. And then it bleeds again, and so on and so on. And eventually it grows. So these are not innocuous lesions. They are potentially very bothersome and even incapacitating. They present with seizures, hemorrhage, or mass effect. And when feasible, radical excision is the treatment of choice. Nowadays, gamma knife therapy is a consideration. On CT, you basically see a hyperdense nodule, and the usual conundrum is, am I dealing with a cavernoma, which is not the first thought, or a calcification, which is the first thought? On MR, the T2-weighted sequence is the best because it gives you the look of the mulberry. This is not a mulberry. I'm not trying to fool you. This is a blackberry, but I was told by the donor that it looks much like a mulberry. So, and as you know, I don't lie. So here's the mulberry. But this is what it looks like on the T1-weighted sequence. On the swan, the susceptibility sequence, it blooms. That's why the swan is so helpful to find old hemorrhages. And then when you magnify it, it does look like a mulberry. Brain tumors, primary astrocytoma and glioblastoma multiforme, and secondary metastasis. These are selected views of a 56-year-old female who had this lesion here. It's a hypodensity on the CT scan. That was in January of 11. In September, she had an MRI scan which showed the same thing, but a lot more striking because this is a flare sequence. And then she keeps coming back for a checkup in 2012, 2013, and 2014. And there is really very little change. And that is the hallmark of a low-grade tumor. Now, not all of them behave like this, okay? There are those that, well, it's like this, for example. This one started out as a low-grade tumor in 06. In 08, you might even say, well, it looks a little better. In 2012, it looks worse. In 2013, they had to do an operation on this patient. Here again is in 06 and in 13, almost the entire hemisphere is affected. So what is the hallmark of a malignancy in the brain? Primary and secondary. It is mass effect, edema, enhancement, which is usually in the periphery and irregular, central necrosis, hemorrhage sometimes, and occasionally calcifications. This patient had a skull lesion, and as you can see, there is a very large degree of uptake on this PET CT scan. This is what it looked like initially. This was in January of 12. And in April, it looked pretty bad. These are more pictures of the April situation. So it's a huge craniofrontal mass with invasion of the orbit, extrusion of the eye. And this patient, I think, had lung cancer. Okay, under the category of infection, we'll discuss meningitis and abscess. The classic appearance, which you don't always get, but it's nice if you do, would be like this here. A leptomeningeal enhancement. This is the T2, this is T1 non-contrast, T1 with contrast. Normally you should see sulci that are black like that, just like CSF. And here, it looks like every single square inch is occupied by enhancement. So this is leptomeningitis. This is a patient with HIV, and even though they are prone to get any kind of infection that you want to see, a common one, which in other immunocompetent people is very uncommon, is toxoplasmosis. Here is the restricted diffusion. Now, as you know, restricted diffusion is usually acute infarct until proven otherwise. This is one of those situations whereby a non-infarct causes restricted diffusion, which is an abscess. So as I was saying, toxoplasmosis is so common that whenever this occurs in an HIV patient, the usual decision has to be made, is it toxo or is it lymphoma? But rather than do a craniotomy and a biopsy, they very often give a trial therapy with anti-toxo agents first. And if that helps, then obviously it wasn't lymphoma. Okay, here's another patient. And up here you have the T1 without contrast. A little bit lower, T1 without contrast still. And then the coronals and the sagittals. This is without contrast up here, and with contrast down here. And you see here, especially over the cerebellum, there are these linear streaks of bright white between the folia of the cerebellum. You can also see it here. And the orientation is different here because this is a coronal image. But this is what a leptomeningitis looks like with contrast, classically. Same images except magnified. The patient actually had melanoma, so even though this hasn't been proven, this was thought to be melanoma metastasis. And occasionally you can get this kind of a meningeal enhancement called sugar coating. Okay, the hallmark of trauma most of the time is a hematoma, and they can be parenchymal or they can be extraaxial, meaning not in the brain, which is then subdivided into subdural, epidural, subarachnoid, intraventricular. And as a separate category, you have diffuse axonal injuries. This is a young woman with a self-inflicted gunshot wound. You can see the trajectory here. And even with different windows, there are no sulcal markings at all. I mean, there is just very, very high intracranial pressure. So high, as a matter of fact, that these are images for a CT angiogram. The contrast didn't want to go up. Okay. This is blood from her initial wound. So this is what Dr. Yang calls no evidence of effective cerebral circulation. Is that correct? Anyway, the patient was brain dead. Hematomas. Okay. A hematoma is one of the few things that is bright on CT without contrast. And they're often in the basal ganglia. This is actually going beyond that. And they are often hypertensive. So you have a large, bright white area, mass effect, and midline displacement, contralateral. This is another patient with a hematoma, and it is very difficult to see. But when you look at the hemispheres, you see that in the right hemisphere there are still sulcal markings. Not complete sulci, except for here laterally, complete sulci. But they're there. On the left, there is nothing like that. This is just chock full of edematous brain tissue. Not because something initially inherently abnormal in the brain per se, but because of an overlying layer of hemorrhage. Now you might say, Dr. Hardja, you just said that hemorrhage is bright. Well, yes, if it's acute. If it's subacute, it starts to become less bright. Or it can still be acute, but if the patient is severely anemic, like a hemoglobin of 7, 9, then the acute hematoma might look something like this. And with different windows, you can see a little bit better. I keep losing my arrow here.
Right foot, make it always stay on top.
So you see that this component, at least, of the hematoma is biconvex, which is more commonly seen in an epidural hematoma. This is the coup contre coup. I mean, this is where the patient banged his head against whatever hard object. And then you get a hemorrhagic contusion, practically 180 degrees. It's also important if you have, once you have categorized all the abnormalities, to do bone windows, because you don't want to miss pneumocephalus, no matter how small. Because an intracranial collection of air means that there is an abnormal communication with either the sinuses, the mastoid air cells, or the outside world. So a setup for meningitis, in other words. This is an epidural hematoma again. It's biconvex. Oh, here it is. It's a very tiny fracture. And you can even, it's almost invisible here. Usually they are not this far anterior, they're a little bit more posterior in the posterior frontal parietal areas. And in that case, invariably, it's involvement of the middle meningeal artery. This is subarachnoid hemorrhage. All images are of the same patient. This is initially on day 1, and this is 3 days later. So you can see that the subarachnoid hemorrhage has not changed significantly, it's still there, but the ventricles are larger. And we often see that. And the reason for that is, in certain cases, you get backflow of subarachnoid blood into the ventricular system, which then obstructs the outflow. But in most cases, there is some decreased function of the arachnoid granulations exerted by this free blood in the subarachnoid space. Now on diffusion and ADC, again, if it's large enough, you can see a small area centrally that has restricted diffusion. This can be confusing because it shows you a ring-like lesion here. And when you say ring-like, invariably you think about something malignant, even though that is usually associated with ring-like enhancement. Nevertheless, it's good if you have old films, and if you follow it up, you can see it's nothing much but a hematoma that just evolved and then slowly disappeared. Diffuse axonal injuries, very often on CT you see nothing. On MRI, especially on the susceptibility sequence, you can see tiny hemorrhages. And invariably they are at the gray-white junction of the brain. That's their number one location. Number two is the splenium of the corpus callosum. And number three is the lateral aspect of the brainstem. So here are the hemorrhages again. And if it's a flare sequence, then you're looking at edema here. And this is the number two location for DAIs, the splenium of the corpus callosum. It's this area here. Much better seen on flare. Infarction, acute, subacute, and chronic. The acute infarct can easily be recognized by the fact that it has restricted diffusion, bright on diffusion, dark on ADC. This has already been of a certain length of time because it's already bright on flare, but not long enough to cause enhancement. There is no enhancement yet. And I don't know whether this was fortuitously, but you can see that the right cerebral, posterior cerebral artery was occluded. Just a few words about atrophy, encephalomalacia, and porencephaly. Normal is something like this. This is a young person, obviously. The gray-white differentiation is still excellent. You see a few sulci, but they are mainly frontal. And according to one of my professors, the reason we have the frontal area prefers to be atrophic is because half the time we are asleep on our backs. So, the brain sags and the frontal lobes become atrophic. At any rate. So as we get older, atrophy sets in and the sulci become more obvious. Compare that with this here. And then if we are unfortunate enough to get an infarct, that infarct eventually becomes Dr. Peter Myers, after whom the library is named, called this brain rot. Okay, and I couldn't be more precise than Peter Myers. So you get this here, encephalomalacia, and eventually it communicates with the ventricle, and then it's called porencephaly. This is a patient with old blood here and here, these little dark areas. And something old is going on here because the ventricle on this side, on the same side, is dilated. On the other side, it's tight. So here it has to fill in for some loss of volume. And now you can see there is Well, no, you cannot see it. Well, I don't have a better image, but there is encephalomalacia here. And these little black dots, by the way, if you draw a line, then you get more or less the boundary between the anterior cerebral artery circulation and the middle cerebral artery. So this is a watershed in form.
When you have an old infarction and the chunk gets big, does that take back to old?
Yeah. Skull-based tumors, central skull-base, that's usually the territory of the adenomas. And there are micro and macro, and then there's the craniopharyngioma, and then a few words about the meningioma. This is a dynamic scan. So the first image here, this is a coronal, by the way. The first image is taken without contrast, and then eventually contrast gets pumped in. And you see here, there is a little area that doesn't enhance initially. Eventually it fills in. Here it fills in completely. And had this been allowed to go on a couple more minutes, then you would have seen the opposite washout phenomenon, where the tumor becomes brighter than the pituitary tissue. But this is called the dynamic scan of the pituitary. So again, to orient yourself, these are the source images, and what I just showed you were these focused shots. This is the technique: 10 slices, the first one without contrast, 9 with contrast, at about half a minute of an interval for a total of 5 minutes. And, you know, there are variations on the same theme. Macroadenoma is an adenoma that attains a size greater than a centimeter in this diameter, vertical, okay? Not horizontal. If it's a centimeter, or if it's less than a centimeter, like here, it's a microadenoma. And then when you have these measurements, then it shouldn't be more than 6 millimeters in infants and children, 8 millimeters in men, 10 millimeters in women of childbearing age, and 12 millimeters in pregnant or lactating women. It's a rather crude yardstick, but it's helpful. This is the pre-op picture of this person with a huge adenoma, a macroadenoma. And here's the T2 weighted axials, proton density. And this is with contrast. Typically, you have the snowman appearance, i.e., there are little ditzels that stick in on the side here, which are the diaphragma macella, okay? It kind of pinches the snowman from the sides. So that was a pituitary macroadenoma which was operated on, and you can see remnants here. Now, the craniopharyngioma has similarities with the macroadenoma, except that they are, if you have a craniopharyngioma that goes by the book anyway, it's a supracellular tumor. Potentially it can arise anywhere between the nasopharynx and the third ventricle, but most common location is supracellular. It is a bimodal frequency tumor, i.e. In the younger years, and then a smaller peak in the older years. And the imaging characteristics are different. The first bump is associated with different intensities, dark and medium, bright, and calcifications. In the older group, you don't usually see them. Now this is a suprasellular meningioma. And again, they don't always read the book, but if they go by the book, then on the actual image, the sagittal image, you see a nice little cella turcica here. And there is tumor all over it on the top. This is the meningioma. Spine disorders, we'll get a look at congenital trauma, degenerative infection, and tumor. This is a patient with a myelomeningocele. As you can see here, the spinal cord goes way too low. Normally it should end in the conus medullaris around here somewhere. And that's because it's tethered here. And there's a sac. So myelomeningocele. This is a patient that sustained acute neck pain, and that's because there's a disc herniation here. You can see on the sagittal, normal disc are linear or maybe slightly bulbous, but if it's this big, it's a herniation. You can see on the stir image the herniation and edema in the spinal cord. Okay, this is a patient in 06 and in 14, and I challenge you to come up with the abnormality. Where is it? Okay, I'll help you out. Same pictures but more selected. And what do you see is different in 14 from 6?
Of the spinous processes.
I can hear you.
Spinous processes, shoes.
Precisely. Or as they say here, bingo, right? They're much closer together. And there's even a touch of sclerosis starting to form here. Eventually they can form pseudo-articulations. And there was actually a case in point a couple of months ago whereby the pseudocyst, if you will, burrowed its way into the spinal canal and started compressing the coda equina. But that is very rare. This is called Bastrop sign. This is a 15-year-old male who was in a MVC and bumped his conus medullaris. And there is a little swelling, a little bruise here. And this is where it should normally end, not way down here like it was with the myelomeningocele. And here is a sagittal of a CT, and you can see there is a vertebra that is destroyed here. And on the axial slice, you can see the soft tissue mass breaching the bony rim here. You see the same thing on MRI, except for the bone detail, which is usually better seen on CT. This was a spondylodiscitis, and this was an epidural abscess. Vertebral hemangiomas, what happens is that the marrow decreases, and therefore whatever bony struts were available became thicker. There were fewer, but they became thicker. And that's why you get this appearance. Looks like a jail window with these bars here. Those are vertebral hemangiomas. And then of course if you cut across, all you see is dots like here. And they can look quite striking on MRI. Okay, who sees the abnormality here? It's in the spine, okay? Forget about the rest of the skeleton. Which one? Exactly. This is called the winking pedicle sign, and it can be deadly if you miss it. So, because usually it is a metastasis. Here it is in magnification. What are these, by the way? Gallstones. Precisely. And here is this huge mat eating into the vertebra. Any questions?